Hello everyone and welcome back to our channel where we discuss different surgeries. Today we are going to explain the pterygium surgery. Now pterygium is growth of the fleshy tissue of the conjunctiva over the cornea, which can cause blurriness of vision, can be a cosmetic concern to the patients, cause irritation of the eyes and recurrent redness and watering. So let's discuss the surgical steps. What we do in the surgery, the first step is that the head of the pterygium is carefully separated. We use scissors to undermine the head of the pterygium. Basically, at the junction of the head and the body of the pterygium, we separate the tissue and then dissect it from the corneal surface so as to remove all of this tissue and improve the cosmetic appearance. It is very important that we clear off all the residual tissue from the cornea, and a number 15 blade is an ideal instrument to clear off this tissue, as it is sharp enough but not very sharp like a crescent knife, which can actually cause a deep dissection or multiplanar dissection. So this tool works really well, and we have to be meticulous and careful and have patience to achieve a very nice smooth surface. Here we are using a diamond burr to further polish and to make sure that we have an absolutely pristine cornea. The next step is to remove the degenerated tissue. So here the cause of the pterygium is actually degeneration of the conjunctiva due to the UV light exposure. So we need to dissect off this tenons or the subconjunctival tissue all around using a combination of blunt and sharp dissection techniques. So we go all around the tissue and dissect it from the conjunctiva overlying this degenerated tissue and underneath the sclera. Then we separate it out carefully. We have to be very careful of the medial rectus, which is the insertion of which is about 5.5 millimeters away from the limbus on the nasal side. So we have to be very careful not to damage that. And once we have excised all of this tissue, we need to dissect it out to make sure that we avoid recurrence of pterygium. And if we can have somebody assist us and hold this tissue while we are separating, it comes in very handy, and the rest of the tissue just falls back. Now we assess the size of the defect that we have created, and we are going to cover this defect with the help of a conjunctival autograft, which is harvested from the patient itself. Now here we have marked the size of the graft that we needed. It is a great idea to harvest a graft slightly greater than what we need in size. We can always trim it down if we end up harvesting a graft which is larger than what we need. So here again we are using these scissors, and instead of using a sharp limbs forceps, we are using a smooth forceps so as not to damage this delicate conjunctival tissue. And as we dissect the conjunctival autograft, we keep on dissecting the subconjunctival tissue, as we can see here, so as to achieve a very thin autograft with minimal subconjunctival tissue, so that it sits in well, doesn't clump up and doesn't cause any problem in the donor side. So we are harvesting this graft from the superotemporal quadrant of the same patient. Now here it is important that for most cases to note that we do not really need limbus in the graft. We are not taking the limbal stem cells, we are only harvesting the conjunctiva. Once we have done this, we have a free graft. We rotate it into the position. When we are opposing it, we need to keep limbus towards the limbus. If we have any tenons, it can be further dissected so that we have a nice thin autograft which sits in well and does not get dislocated from its position. So first we check the size of the graft, and if it is slightly larger than what we need, then we can always trim it down. And then here in this case, we are using atovicryl sutures taking slightly scleral bites so that the pterygium graft anchors well and sits well in position. There is no collection of heme under the conjunctival autograft. So we are taking interrupted atovical sutures. These are absorbable sutures. They take about 6 to 8 weeks and they get absorbed. A better alternative is fibrin glue, but this patient unfortunately could not afford fibrin glue. He was a poor patient, so we went ahead and did the surgery using these sutures, which give also an excellent outcome to these patients. Very important to trim the overhanging excess tissue in the end to improve the cosmesis, and then we inject subconjunctival steroids as well as antibiotics, and that's the end of the case.